We have Dr. Lee coming up to talk again about, as a retina guy, this is a lecture I'm definitely going to be paying close attention to. Things not to miss in neuro-ophthalmology.
It doesn't matter whether you're cornea or glaucoma or orbit or comprehensive. These are 5 things that nobody should miss, and this lecture is for the residents, okay? No eye resident or any IMD should miss these things. It's your chance to save someone's life in ophthalmology. I have no financial interest in the contents of this talk. I will not be discussing any off-label uses of drugs. I told you that this thing was a motivating force in my life, and so I care a little bit about your evaluations. P.S. Make them good. But I want you to remember this day. I want you to remember the day you heard about me and space and saw me in high school. And then when the patient comes, you will hear my voice in your head. The voice sounds like this. It still could be giant cell. It could be apoplexy. Do you understand? When you hear that voice, do not ignore it. I told you when I was a kid, like every kid in 1969, I wanted to be on the moon. But you chose something greater than yourself. You wrote this in your personal statement. You must be the doctor your mom already thinks you are. You must strive to use the force. The force is called neuro-ophthalmology. We literally get to look in people's eyes and see death, disease, the Reaper himself. It turns out that the Jedi superpower, the force, is real. Only neuro-ophthalmology can save these people, not Superman himself. None of Superman's powers would help. His super strength, his laser beams coming out of his eyes, none of that will help solve the riddle of pupil-involved third nerve palsy. You are the superhero. So our ability to look at people's eyes, see and deflect the Grim Reaper, that's a true force. So if you take nothing else away from this part of the talk, it's this: use your power wisely. You have been given a great gift. The gift is called being a doctor. So I want to share with you 5 potentially life-threatening diagnoses in neuro-op. I want to define for you the rule of the pupil. Pupil-involved third nerve palsy is aneurysm, the posterior communicating artery until proven otherwise, and how we've modified the rule to mean just scan third nerve palsy, and define the best imaging study for these 5 diagnoses, and show you the key clinical and radiographic feature that will help you make the diagnosis. So these are Lees. This is when you will hear my voice. Arteritis, giant cell, apoplexy of the pituitary, abscess from mucormycosis or aspergillosis, aneurysm, that's the rule of the pupil, pupil-involved third nerve palsy, and arterial dissection on the carotid side or on the vertebral side. If you listen, you will hear my voice the day this person comes to your eye clinic. And so, everyone in this room, including lay people like Jim, have heard so many lectures, they know giant cell arteritis. Okay, I know that one. I heard that one before. What everyone knows: elderly patient, often female, acute onset, headache, jaw claudication, temporal artery pain, neck pain, ear pain, loss of vision from ischemic optic neuropathy, elevated SED rate, and CRP. Isn't that GCA? My kid knows this is GCA. The thing you don't know is it's called temporal arteritis, but the temple is not where the action is. It is a medium to large vessel vasculitis. That means it affects every artery. So my residents love to go into rooms and mash on old people's temples, and they say, well, they didn't really have temporal tenderness. Who cares? Temporal arteritis is called temporal arteritis because we do a biopsy there. It affects every branch of that artery, every single branch. And that means it could be temple pain, it could be neck pain, it could be ear pain, it could be face pain, it could be any pain in the external carotid distribution. And the reason it's dangerous is patients come in and they just kind of tell you they have this pain, but they have a normal eye exam. So you're going to be tempted to write this: impression, normal eye exam. Plan, go see a real doctor about your pain. You're the real doctor. What are you talking about? You are the real doctor. You are the real doctor. If you look at this series from Hunter et al. From Mayo Clinic, all biopsy-proven giant cell, 100 cases, look at the top 4. The top 4, headache. There are no diagnostic criteria for the headache of giant cell. That's because there's nothing about the headache that says it's giant cell. They're in all the other headache syndromes, migraine, cluster, trigeminal, SUNCT, SUNA, cluster, they all have criteria. There are no criteria for the giant cell headache. It can literally be the worst, the mildest, the moderate. It has no criteria. Number 2, polymyalgia rheumatica, PMR. That's proximal hip and shoulder girdle pain and morning stiffness. If you ask your average 80-year-old patient, do you have joint pain? They're going to say yes. I'm 57. I have joint pain. Do not ask me that. You should ask hair, chair, stare. Does it hurt to comb your hair? Do you have pain when you get out of the chair or when you climb the stair? If yes, where's your pain? Proximal hip and shoulder girdle, that's PMR. And is it stiff in the morning? Do not ask 80-year-olds if they have joint pain. They do. They do. They all do. Fever of unknown origin, FUO. In my hospital, they're getting a chest x-ray, a UTI workup, a CBC, and if all that's negative and the blood cultures are negative, they're going to call for a temporal artery biopsy. So FUO in elderly person is also GCA. It's number 3 on the hit parade. And the one that matters to us, number 4, visual symptoms without loss of vision. That's amaurosis fugax, transient vision loss, or transient diplopia. No vision loss. They have a normal eye exam. So please don't ever write this impression normal eye exam. That is not a diagnosis. And if you're retina, please never write this impression, not the retina. That is not a diagnosis. Not a diagnosis. Not a diagnosis. You have to have a diagnosis. So if the person is complaining about pain, PMR, FUO, you got to be a doctor. There's a reason you went to medical school, and that reason was not to inject people with anti-VEGF agents. Your job is to be a doctor first, ophthalmologist second, yes? Vitreoretinal surgeon third, in that order. So if you look at GCA and MS, the wine countries. So my theory, this is a joke, my theory is that wine causes giant cell, because you look at the giant cell countries here, it's where all the great wine is. So all kidding aside, these disorders have an equatorial preference, both in the northern hemisphere and the southern hemisphere. So the same locations in the northern hemisphere that produce multiple sclerosis and cause the Caucasian predilection for giant cell and MS also occurs in the same latitude in the south. Those latitudes are exactly the latitudes where good grape wine countries are. And so in the southern hemisphere, Argentinian Malbec, South African Chenin Blanc, but not the rest of Africa, Australian Shiraz, and New Zealand Sauvignon Blanc. That's where MS is, and that's where GCA is. All the equatorial regions. In fact, I just met someone from Gabon. Gabon, giant cell would be a Gabon grand rounds. They'd be like, wow, giant cell in Gabon. It'd be a super rare thing, okay? So when I give talks in other countries, I give them the list, and sometimes they write back and say, why do you want to talk about these rare things? Giant cell, multiple sclerosis. I'm like, oh, shoot, forgot. I'm going to Gabon. They don't have that. If you look at this British Journal of Rheumatology study, biopsy-proven people who lost their vision, 146 biopsy-proven giant cells, 16% of the people, 23, lost vision. They had GCA symptoms on average 1.3 months prior to going blind. 35%, 1/3 of the cohort, had polymyalgia rheumatica, hair, chair, stare, on average 10.8 months before losing their vision. 65% of the people had transient symptoms of vision loss or transient diplopia before they went blind, on average 8.5 days. Somebody saw these people and didn't make the diagnosis. I don't want that to be you. Clear delay in diagnosis. In 15 of the 23 people who went blind, 65% of these people, someone should have been a doctor first and an ophthalmologist second. And the MRI scan of the head was normal. Why? There is no MRI finding of GCA. You're wasting valuable time. They need a SED-rate, CRP, temporal artery biopsy, steroids. So this patient is what I would call a duck. My dad would say, if it looks like a duck and flies like a duck and quacks like a duck, it's probably a duck. A 20-year-old white female with acute loss of vision, pain with eye movement, RAPD, and a normal fundus. The doctor sees nothing, the patient sees nothing, there's nothing to see. Only RAPD, retrobulbar. Everyone in this room knows this is optic neuritis. But what if I change the stem to 80-year-old white female with acute unilateral loss of vision, RAPD, pain with eye movement, normal fundus? Should you tell this 80-year-old, you know, you have optic neuritis? And we got to worry about MS. You know, you're like 80 years old. Now, can MS occur in an 80-year-old? Yes, but man, that's not a duck, okay? That is not quacking. That is moo, okay? Moo, moo. So retina, looked at the retina and said it was normal. They did an OCT of the retina, which was normal, and they wrote this, impression, optic neuritis. That's a giant cell. Fluorescein angiogram was performed, massive choroidal perfusion deficit. So now we have to write back to retina and say, impression, it is the retina. Please don't write optic neuritis in the chart of 80-year-old people. That's giant cell. So the wicked good pearl, retrobulbar optic neuropathy in an old person is PION until proven otherwise. Posterior ischemic optic neuropathy. This you do need an MR for because it might be apoplexy or something terrible. But you need to think about giant cell when the fundus is normal. And you need to think about it when the disc is pale and swollen at the same time. We call that pallid edema. Pallid edema, very bad. Never write that unless you're going to write a prescription for steroid right afterwards. So, the big red flags, severe vision loss, LP or NLP, that does occur in a non-arteritic form of AION, but it's rare. Bilateral simultaneous, that occurs in the non-arteritic form, but that's rare. Transient vision loss, that does occur in NAION, but that's rare. So this is moo, 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 moo. No quacking here. All this is quacking the wrong direction, okay? And if they have hair chair stare, PMR, badness. PMR plus visual symptoms is a special kind of PMR called GCA. They're the same disease. So a PMR patient that says I can't see is GCA. So there are 5 things I want you to remember about GCA, elderly loss, vision, pain, headache. One's giant cell. The other 4 things are giant cell, okay? So, holiday headache. Switching gears, 22-year-old woman, severe headache, 2050, question effort is what the tech write. Fundus is normal, Humphrey completely unreliable because it's completely black. The reason is she has the worst headache of her life. Your tech gave her the clicker, and she's like, my head hurts. When are they going to come back? The field is going to be completely black because she's not pressing the button. The reason she's not pressing the button is she has the worst headache of her life. And she's hand motion. So you put a blind person with a severe headache inside the why are you doing that? Okay, it's Friday, 4:45 p.m. The standard of care does not change based on time of day. Your birthday, your anniversary, your dinner plans, your tea time. It does not change. Almost all of the medical legal cases that I review have some element of laziness in them. That's sad. Right? Is it because the step 1 score of my retina doc was not high? Is it because he didn't go to Bascom Palmer? That's not the cause. The cause is Friday, 4:45 p.m. That's the cause. So, please don't write this, Humphrey, unreliable, and then walk away. You have written, I have no visual field on this patient, and I don't care. You're not trying to detect some arcuate scotoma here. You're trying to detect bitemporal or homonymous hemianopsia. You can do that with your fingers. You don't need no fancy machine to do this. And in the ER, there's no Humphrey. And that means the whole case is whether the first-year resident on call can do a confrontation visual field and detect a bitemporal hemianopsia on a patient. Isn't that scary? So, the life-threatening diagnosis for bitemporal hemianopsia is apoplexy of the pituitary gland. In the book, it says Sheehan syndrome, which is great. Sheehan, you need to know it. Pregnant lady, postpartum. But almost all the apoplexies are not pregnant ladies that I see. If it was pregnant lady, it'd be so easy, right? So easy. Incidence of pituitary tumor, 7 per 100,000, maybe 1 in 500 over age 65. So if you're over age 65, and you probably know 500 other 65-year-olds in your community, if you can't figure it out who it is, it's you. It's you, okay? 1 in 500. This room right here, probably someone is harboring the pituitary adenoma right now. They don't know it. Right now. One of you also has an aneurysm. You don't know it. Don't you think that's scary? Maybe it's me. My friend Barrett Katz says the average ophthalmologist should see 1 pituitary tumor per year. Are you missing your quota? So here's what apoplexy quacks like. Acute onset, severe headache, bitemporal hemianopsia. 8% of the people die. You kind of need your pituitary gland. It's the master gland. And if you don't have cortisol at 4:45 p.m. on Friday, and 4:45 a.m. on Saturday, when that cortisol needs to kick in and isn't there, they die. That cannot wait for next available Neuro-Op. The next available Neuro-Op in Houston, Texas is January the 5th of 2022. That is my next available appointment. The only way you can get anybody to see me is if you know me and call me on my cell, or you send them to the hospital. We'll always see them. However, our hospital now has 576 COVID-19s. There are now 100 people in our emergency room waiting for beds. Waiting for beds. So if you haven't got the vaccine, you know how I stand on that. Come see me after class. Hypopituitarism, it kills people, and you need an emergent scan. So this is the scan we're looking for. Hyperintense rim surrounding hypointense core. That was the adenoma that was there that you didn't know about. It bled, and that thing at the top is a beret. That's my chiasm, producing the bitemporal hemianopsia. If you look at this Semple et al. Series, 62 patients, average age 51, average time to presentation 14 days after the ictus. So they had the worst headache of their life. That was 2 weeks ago. Then they called your office to make an appointment because they got blurry vision. Their headache got better. They don't tell the scheduler about the headache. And then you see the patient and they have bitemporal hemianopsia. That's still apoplexy. So the headache and the onset of the vision loss occur simultaneously, but when you see the patient, the headache is long gone. You need to know that sometimes there's no headache. It's just bitemporal hemianopsia. 13% of the people, no headache. And 73% of the cohort, panhypopit. 8% had diabetes insipidus, DI. That'll mess up your electrolytes, and you will DIE if you have DI. You need to have sodium on board. And apoplexy, we make the diagnosis, not the radiologist. So what does it sound like? Acute, painful, bitemporal hemianopsia. That's apoplexy. I don't care what radiology says. Apoplexy. Admit. So the big behavior change. If you've got an unreliable field, please do a confrontation field. You are trying to detect bitemporal hemianopsia. If you leave it like that, unreliable, Humphrey, you are saying, I have no visual field. It could be a brain tumor, but it's my birthday, so I'm going out to dinner. Don't do it. This is a 35-year-old white male with diabetes with a history of diabetic ketoacidosis. They have a complete left-sided ptosis and an almost complete ophthalmoplegia on the left. What's the worst thing this could be? Now, it could be a diabetic palsy, mononeuropathy, vasculopathic. It's just going to go away. You need to eat a good diet and control your sugar and your blood pressure, or it could be life-threatening mucor abscess. The thing in the stem that makes it mucor, almost complete. So, my residents get so excited when they see third nerve palsy. The lid is down, the pupil is blown, the eye is down and out like this. Who would miss that? Even orthopedic surgery knows that's a third nerve palsy. But you need to test the other cranial nerves. They're numbered for a reason. 2 lives next to 3, 3 lives next to 4, 4 lives next to 5, 5 lives next to 6. You cannot do this. I'm going to check 2, 3, 4, skip 5, 6. Are there other cranial nerves? I don't know. I don't ever test those. You cannot do this. You have to be able to test to at least 8. And in a third nerve palsy, we need to test the ones that are above and below the 3. The 2 needs to be tested. So, the person has a pupil-involved third nerve palsy. Their pupil is fixed and dilated. Their eye is down and out. What would move that from being aneurysm, the rule of the pupil, to orbital apex? From mucor, the presence of the 2, or the presence of the 4. In order to test the 2, you must use the other eye. That's called a reverse RAPD. So we swing the light from the right to the left. We cannot look at the right pupil because it's fixed and dilated. When we swing the light back to the right eye, we're going to look for dilation on the left. If the left dilates, you need to image the orbit, not be doing a CT, CTA, which is our normal protocol for aneurysm. You are imaging the wrong area for the wrong thing because you didn't look for 2. If it's 4, the eye's down and out, we're going to be looking for intorsion in down gaze. Intorsion like this. That's what the superior oblique does. If you don't see it, the lesion's in the cavernous sinus or the orbital apex. That also is not aneurysm. That's mucor. So if 2 and 3 or 3 and 4, Mucor. Life-threatening diagnosis, mucormycosis abscess. It looks like this on the radiograph. The sinus is enhancing and enlarged. The adjacent cavernous sinus is involved, or orbital apex. This is a 76-year-old woman who I saw at Iowa with AML. She was on induction day chemo 13. The resident was called to the floor because the complaint was 2 days of worsening right-sided periorbital swelling and erythema, no pain, no white count, no fever. Just lying there comfortably, little bit of erythema in the lids, chemosis. CT scan was performed, which showed mild pansinusitis and some fat stranding in the orbit. Rule out inflammatory orbital pseudotumor. Do you think this person who is immunosuppressed and has AML has idiopathic anything? Please do not give the diagnosis of idiopathic to people who have pathic. This is not idiopathic, okay? And it's going to be super dangerous because you're going to want to give steroids. As soon as they say Tolosa Hunt or idiopathic orbital pseudotumor or whatever. And ENT went up the nose and biopsied it, angioinvasive mucor. So afterwards, I told our resident, I said, how come you got to think about mucor, infection? He said, Dr. Lee, there was no fever. How come there was no fever? No immune system. There was no pain. How come no pain? No immune system. There was no white count. How come no white count? You're induction day chemo 13. There's not going to be any white count. You're neutropenic. So this person doesn't look that sick because they're super sick. All the things you've been trained to look for infection and inflammation, dolor, calor, rubor, tumor, red, hot, swollen, painful, none of it will be present in the immunocompromised person. They will look like nothing when they have this. In the book, it says to look for this black eschar thing. Do not wait for this black eschar thing. By the time the black eschar comes, the game over. Oh, Dr. Lee, there was no black eschar. Who cares? Who cares? Nobody cares. And the MRI scan of the head was normal. So how could the head be normal? Fungi, black. Just little dried out fungal hyphae, no water. You need water to see on MR. So you need to look for what the distinctive sign is, which is contrast enhancement. So wherever you see optic nerve enhancement is next to whatever they see in enhancement in the sinus. That is the radiographic sign that it's fungus. You saw that in one of the presentations. The sinus disease was causing the eye problem because what they saw was next to what we saw. And this happens to be aspergillosis. So this is going to be read as there's enhancement on the left consistent with optic neuritis. There is, quote unquote, incidental ethmoid sinus disease. Now, I like radiology. Some of my best friends are neuroradiologists. They don't know anything is incidental. Never believe them. How do they know if something is incidental? They didn't see the patient. That's why they went into radiology. They don't like seeing patients. Don't believe them when they write that incidental. How do they know it's incidental? It is not incidental. By the way, incidental is the opposite of what you think it means. Incidental means it's related. Coincidental, that's what you meant to say. Coincidental. It was fungus, aspergillosis, biopsy proven. What happens if you don't give the contrast material? You can't see anything enhance if you don't give the contrast. That's my house at night. Why didn't he give the MR? Well, they're diabetic. They're diabetic nephropathy. They have terrible kidney disease. They have chronic kidney disease stage 3. They won't give the gadolinium because they're afraid of nephrogenic systemic dermatopathy, a gadolinium-based disease. You need to know a little bit about fat suppression. Fat is very bright on T1. It's too bright. So here's fat, too bright. No gadolinium yet. The fat is bright. It's normal. Fat, normal. But after you give the gadolinium, if you don't suppress the fat, how are you going to see the enhancement? So white stuff on top of white stuff is white stuff. You cannot see this nerve enhancing because you did not suppress the fat. And this MRI scan will be read as normal. They should say this, hey, dummy, you did not order the fat suppression, and therefore we cannot tell you whether the nerve is enhancing or not. Perhaps you'd like to go and read the book about orbital fat suppression scans before you order an MRI on this patient. It doesn't say any of that. It says this, impression, normal, contrast, MR, non-fat suppressed. That's all it says. White stuff on white stuff is white stuff. Polar bear in a snowstorm. So, CT is the imaging study for abscess. You can see on the MR, fungi, it's dark. So on T2, the fungus is completely dark. So that MR says nothing's in there, but the same day CT says it's chock full of fungus. This is a 60-year-old diabetic man who looks like third nerve palsy again. Adduction, elevation, depression, 45 prison doctor, exotropia. Doctor writes, ischemic, third nerve palsy, plan, come back in 6 weeks. Never do this. Always image these. Image these. Because acute pupil-involved third nerve palsy is aneurysm until proven otherwise. That's the rule of the pupil, posterior communicating artery aneurysm. And you can see the jalapeno pepper there. If you rupture, half the people die at the scene. If they make it to the hospital, half those people are permanently neurologically impaired for the rest of their life. If we diagnose this before the rupture, coil or clip, go home hospital day 3. It's a save. So I see this probably once a quarter that I save somebody from the reaper. The average ophthalmologist sees this once in their career. Who's already seen it? All the rest of y'all, get ready. Coiled it, it's a cure. Coil, clip, cure. If it ruptures, they die. So here's the imaging study of choice, CT, CTA to look for subarachnoid hemorrhage, followed by aneurysm for all pupil-involved thirds. You need to do MRI, MRA if the CT, CTA is negative, because you're looking for non-aneurysmal causes of third nerve palsy. And if you still think it's an aneurysm, catheter angiogram. And I told you need to check for that RAPD. Even if the pupil is fixed and dilated, we only need one working pupil. We have to have 2 eyes, but we have to have only one working pupil to detect an RAPD. If it's a 2 and a 3, not an aneurysm, orbital apex, Mucor. And you know the story on the Mucor thing. Look at this omic data. You can see Neuro-Op is a very small piece of the ophthalmic mutual insurance company data. We're nowhere near what missed retinal detachment or cataract surgery complications are in terms of cases. But here's the payouts. Neuro-Op. Right next door, peds. God help you if it's pediatric Neuro-Op. Just take that thing and put it on the other one. Going to end with this case here, which is painful anisocoria after car accident. Life-threatening diagnosis here is Horner syndrome. Acute, painful Horner syndrome is a dissection of the internal carotid artery until proven otherwise. Don't waste any time with aproclonidine, cocaine, all those drops. Just scan them. Hypothalamus down to T2 in the chest. I love this sign. It says, touching wires causes instant death. There's also a $200 fine. And the MRI scan of the head was normal. Why? You didn't image where the problem is. So the 2 places that kill people, the pancreas tumor in the chest and the carotid dissection, are below this line. Shouldn't the radiologist say, hey, dummy, you ordered an MRI for a Horner syndrome, but you only imaged half the pathway. Perhaps you'd like to send the person back so we can image the rest of the pathway. Don't let that happen to you. What we're looking for is this, a carotid dissection, hyper-intense signal intensity surrounding that hypo-intense flow void. If you do this, aspirin a day, survive. If you don't, stroke in the next 24 to 48 hours. So in summary, what I've shown you is 5 potentially life-threatening diagnoses in Neuro-Op, defined for you the rule of the pupil, but I would prefer you just do CT, CTA, followed by MRI, MRA for any third nerve palsy. I would define for you the best imaging study and the clinical and radiographic features that help make the diagnosis. The 5 A's, arteritis, apoplexy, abscess, aneurysm, and arterial dissection, either the carotid or the vertebral. But really my main teaching point is that you use your superpower wisely to deflect the reaper. It's also our best defense against physician burnout. Our only defense is finding personal and professional satisfaction in saving people's vision and saving people's lives. That is how you defeat the reaper. I cannot change your income or bureaucratic tasks or the EPIC or your EMR. I can't change none of that. But I can inspire you to do better, to do your best, to be the doctor you wrote about in that personal statement. Bottom line, it's your job. Cataract, cataract, cataract. Oh, third nerve bump in the... Oh, cataract, cataract, cataract. No. Scrape that sucker off. There's only one thing to say to the reaper. When the reaper comes, only one thing to say. Not today. Not today. Not today. One person can make a difference. Everyone should try. And you will hear my voice in your head when that day comes. And I thank you for your time and attention.